Hi guys, I thought we'd do a little case today, and I've got a friend, a former student, who's going to help me with this case. We're going to do a little case discussion. So he's about to dial in on Zoom, so hopefully we'll get him here in a second. And his name is Dr. Erik Walker. He practices over in Bainbridge Island on the west side, and he should be here any second now. Eric.
Hey there.
How you doing, man?
Hey, doing pretty good, Dr. Hines. Good to see you again.
Good to see you.
Yeah, thank you.
How's things? I heard you were just come out of quarantine. How was that?
Hey, it was pretty good. We weren't too sick, and we got to enjoy from the house this beautiful weather that we've been having here in Western Washington.
Oh, sweet. That's nice.
Yeah.
That's good to see you. So, when's it been? You graduated 2 years ago, right? So it's 2018.
Yeah. Yep. Graduated 2018. So come this June, I'll have been in practice for 2 years.
Wow. So how's it going? You liking it?
Yeah, absolutely. I'm working here in Western Washington at a small animal with exotic practice, and we see just about everything you can imagine. The only thing I don't work on is horses and cows.
Oh, yeah.
So
True.
anything else is fair game,
Okay.
including salamanders and frogs.
Wow. Wow. You didn't learn any of that from me, that's for sure.
Not even the exotic ward did that. So
Yeah, I guess that's true. Hey, these guys probably don't want to listen to us chat, so we can catch up another time. But I appreciate your working through this case with me.
Yeah.
So maybe we'll just get started if that's okay. I sent you some stuff. Did you get that all right?
Yeah, I did get that.
Okay. Well, let me. Oh, I lost you there. Okay, let me share the screen with you, and we'll kind of work through this case here.
Okay.
And are you seeing that?
There we go. Oh yeah.
You know that guy? Remember that? You remember that day?
I do remember that day. There's a lot less stress then.
All right. So here's this case has got your name all over it. I actually put your name on it. So
Okay.
well, you got the case that you sent it to you. It's the same version that my students got this year. So you look through it, and this is Keeper, who is a 6-year-old Chesapeake Bay Retriever, and he presented just for routine vaccines and annual checkup. But the owner also said it seemed like he'd been lethargic for a couple of weeks and just wasn't. He was less active and just not himself. He said he was eating, but he didn't seem very interested. Usually he was a real chow hound, but he wasn't going at it. And so they also thought maybe he lost a little weight. Kind of not a lot, but just a little bit.
Mm-hmm.
So not a lot to go on there. On the physical exam, which again, I think you've got it. I think you got all this in the stuff I sent you. It was pretty unremarkable, but he was bright and alert and quiet. He was a little thin, so 2'7", 75 pounds. And you look at your records, he lost about 5 pounds from when he was last seen 2 years ago. And then normothermic, kind of a normal respiratory rate and heart rate in the normal range. And so that's kind of where you start. So you don't really have a lot to go on. So, I mean, what would you recommend at this stage, Eric?
Yeah, so myself personally, especially if the client's open to doing more diagnostics, because everything is so general and it's really hard to just tell from this, I'd probably ask them if they would be open to doing some lab work.
Okay.
The first step, because I could get that right away.
Kind of get that right away, kind of get a little more information.
Absolutely.
And that's kind of what how the other veterinarian handled it, and kind of and the owners agreed to a CBC and panel, which I think I also sent you, right?
Yes. Yep. I did get a chance to review that.
So you got a CBC and panel. So here's the CBC, which again, you've had a chance to look at. Anything here that catch your eye?
This is pretty unremarkable. It's not really pointing towards anything specific that I could pinpoint as to what the owner was concerned about anyway.
All right. There's no anemia, no leukocytosis. No, it's all within normal limits, isn't it?
Yeah.
Okay. How about the panel?
Yeah, so this one definitely had a couple more things that caught my attention. In particular, the protein component of this, and that would be the hypoalbuminemia that I noticed there.
Yeah.
Which is that 1.6. The other components that are there's low protein, total protein anyway, as well as the calcium. But it's really the albumin that was kind of catching my eye there.
So what are you kind of thinking at this stage? Is that worry you a little bit, or what kind of things are on your mind when you look
Yeah,
at?
no, it is definitely of concern when you see protein that low, because it means that it's being lost somewhere in the body. And you really want to go on that hunt, because that could contribute to what you're seeing with a patient like this. And so I'm definitely kind of trying to either expand your physical exam or do some more testing would be warranted at this time.
Okay. Anything else besides loss that could be accounting for that?
Yeah, so there's a couple other things. So outside of loss, there could be a dietary issue, whether the patient isn't on appropriate nutrients or actually being fed. Less likely in this situation. I assume it's a good owner. And then the other one, if there's a production issue, if the body's having a hard time producing the albumin, would be another concern.
And so what would be the target organ there if it was a production problem?
Yeah, that would be the liver. And I kind of bypassed that in a way, just because I looked here and I saw the ALT, the liver enzyme, being completely normal, well within normal limits there. And so I kind of bypass it, but yes,
Yeah.
I could have brought that up.
Yeah, you get that can sometimes you can sometimes have normal liver and kind of end stage. I mean, lower enzymes on end stage liver disease, but it certainly doesn't look like anything look like liver disease so far, does it?
Yeah.
So if I ask you to do a problem list, which I know in real life, well, one thing I want to ask, what do you think about? You said this protein was low, but it looks like it's albumin and globulins are normal. Does that have any significance to you?
Yeah, well, it does. One, because the albumin is a much smaller protein in comparison to the globulin. So my one thought is, wherever this protein in this situation, if I'm thinking loss versus production, all of that is occurring, it's in a very specific location. In particular, it'd be areas where small particles could only get through.
Okay, all right. So I started to ask you about a problem list. I know this is probably something you'd be doing in your head in a situation like this, but what would your problem list look like in a case like this?
All right, so yeah, I remember you hitting this hard a lot in class. Oh, um, so going off of the lab work, my first one would be that hypoalbuminemia. We'd have the low total proteins, as well as the low calcium. Really low yield would probably be just the lethargy, inappetence, or suggested weight loss that was maybe occurring.
Okay, all right. Yeah, let me see. This is what I kind of do these in order, kind of when they present them. So just looking in, they came in and had weight loss and lethargy, and then hypoproteinemia, hypoalbuminemia, and hypocalcemia. And the weight loss didn't actually add that, which it should be on that list actually, especially when you documented it in the record.
Mm-hmm.
The thing about this calcium level, does that disturb you at all?
Not as much. I mean, in part, it's really because oftentimes the calcium in part is bound to those protein molecules. And so if I have low protein, that's most likely where that calcium component, why it's low.
I think it's just coming across low because the albumin is low, and I think about half of it's bound to calcium in the serum.
Yeah. Yep.
All right, so you're not too worried about that one. So you might remember when you're a vet student, we get people to think about these kind of formal case representations. So this is one that I wrote. So just a real quick couple of sentence summary. It's an adult Chesapeake Bay Dog Retriever presented for vaccines and vague signs of lethargy and weight loss. It documented at 5 pounds since its last visit. The only finding on the CBC was hypoalbuminemia and hypocalcemia. The key features were just vague signs, and really the only high yield problem is the hypoalbuminemia. Does that all sound about right to you?
Yeah, no, I think that's right on.
Okay, sweet. And just a couple things for the first years here. You've already alluded to this, and I know this is part of your knowledge base now. But for these guys, to kind of remind them that when you look at the total protein in a serum sample, you're kind of looking at two fractions, and you add those up. That's the total protein, so it's albumin and globulins. And so those numbers are what come together. And what you're described in this case in Keeper was the albumins are low, but the globulins are within normal range.
Yeah.
And you pointed out that's kind of different if you have what they call a pan-hyperproteinemia, where both the albumin and the globulins are both decreased. And you mentioned that makes you think of some different things because the globulins are they're a more heterogeneous bunch of proteins, but a lot larger.
Hmm.
I think albumin's like 60 kilodaltons, and the globulins could be as high as 200 or so.
I do not remember that, but yes.
I don't know.
Small versus large, okay.
Yeah, small versus large works pretty well, doesn't it? All right. Okay. So, and here's another thing. You did this just the way, and you clearly have a systematic approach in your head about how you approach the albumin. And so this is kind of what you said. The three things you talked about were increased loss, decreased production, so liver disease, and maybe decreased protein intake for malnutrition or malabsorption. Does that seem fair?
Yeah, I think so.
So what are you thinking about for loss? Can you expound on that a little bit as far as specifically what you're thinking? I mean, first in general, just the general things you think about, but then what do you think might be going on in this case that you want to think about?
Yeah. So, whenever I do a physical exam, of course, your hands are completely on the patient and evaluating. And so you think about loss, and that could be into a body cavity. And so feeling the abdomen, listening to the lungs, how well you can hear things in there.
Mm-hmm.
And so that would be a first thought. You're kind of looking at and talking to the owner always about poop. Believe it or not, it's one of the number one things you have a conversation about, and kind of seeing, has there been diarrhea, digestive issues, anything like this? Usually an owner does bring that up though.
Yeah.
Feces is one. If there was a concern for a burn, which this doesn't indicate that was an issue, you can lose things there. But kidneys is another big one, and we see that pretty often.
So losing protein to the kidney. So you again, things you talked about were the places you could lose it would be the GI tract and feces, so your poop talk. The kidneys, through the skin like in burns, and obviously that's something you would see. You mentioned body cavities where it gets sequestered, and you mentioned both the abdominal cavity and the chest. And the other one you didn't mention though, which makes sense because it was hemorrhage, and you didn't see any anemia. So, if it was losing protein from hemorrhage, it'd lose red cells too, so you'd see anemia. So that one doesn't really fit in this case. So yeah, that sounds great. So what are you going to do to try to sort this out?
If I'm kind of narrowing this down, I think the next one, and it's a simple test that we can do in-house, would be a urinalysis.
Okay.
And that'd probably be the next thing that I'd want to check out on this patient.
Pretty easy too if you can get some urine, huh?
Yeah.
So how about if I gave you this urinalysis here? So you've got a dipstick in the middle, kind of the gross in the specific gravity at the top, and then here's the sediment down here, so the microscopic, and so that's the dipstick right in here. Anything in the bottom is the microscopic, so what you'd see if you looked at the spun sediment. Anything catching your eye here, Eric?
So overall, I can see that the patient is still able to concentrate his urine.
Okay.
We're good there. Of course, going down, I see that there's a lot of protein in that urine. But what I don't see is any blood, and at least here it doesn't necessarily indicate, I guess it would indicate otherwise, any bacterial infection.
Yeah.
Those are two things that I always look for on urine, because those can automatically elevate the protein.
Okay.
And so if I don't see those, then I really think that, okay, there is a protein loss most likely going on here.
So you said he's got concentrating ability there, so the tubules seem to be working, and the BU and creatinine were also normal, so that kind of fits. And then you said the big thing that got your eye is the protein, which is kind of top of the range there. And just so I make sure I follow you, you said you thought it was important there was not blood and there's not any evidence of infection, right? So no white cells and no bacteria seen. Because if it was blood or infection, then having protein would be explained by blood or infection, I guess.
Yep.
Does that sound right?
Yes, right on the nail.
Okay. I'm doing okay so far.
You're doing fantastic.
Yeah, you go. So are you. I just making sure we're together on this. And so, yeah, so no signs of urinary tract infection, or you said it, or bleeding into the urine.
Yeah.
So, taking my students back to their problem list, we can upgrade this hypocalcemia to the albumin. You said that, you attributed that, you weren't too worried about that. And you think this is associated, you said the hypoproteinemia is all about albumin, and you're attributing that to the proteinuria. So how do you summarize things so far? What are you thinking?
So, I would start to consolidate this a little bit more and start putting them together. So, that probably number 4 I would even bring up now as part of upgrade to number 6.
Right. Yeah. Perfect. I agree. I've got that built into it, so we'll just have to imagine that.
And so, with this being proteinuria, then I would start to look at, of course, the kidney and, what part of the kidney is now being affected and trying to figure that out.
Okay. So what do you I mean, the fact that it's protein and it still seems to be able to concentrate urine, does that affect your thinking in any way? I mean, what do you think is going on here? Can you localize it in a more specific way?
Yeah, when we start to see this type of thing happen, we're kind of looking at the filtration system of the kidney at that point.
Okay.
And we're kind of narrowing it down, most likely to the glomerulus is one of the areas of concern that I would have here, because that happens to be the spot that if we're starting to have any type of inflammation, anything like that, it's going to start leaking.
Okay.
And that's where proteins can be lost pretty rapidly.
Okay, sweet. So let me see if I can remind the first year students from last year. So they remember this is what the glomerulus looks like, kind of in 3 dimensions. And you've got the afferent and efferent vessels. It's got the vessel comes in and you've got this glomerular membrane. And typically cells and proteins and things are excluded from the filtrate from the tubules, right? And so it's meant to be a tight membrane here. A little bit that does leak is usually reabsorbed in the tubules, but it shouldn't be very much.
Yeah.
And so what you're saying is this glomerulus here is leaky. And so protein from the plasma, especially the small albumin molecules, are leaking into the tubules and they're being lost in the urine. So you said it better than I did, but I've got figures, so.
I just got memory to go back on.
Yeah. So we've got a problem with the filter. It's a leaky glomerulus. Yeah. So do you kind of have a working differential diagnosis or what you're thinking right now?
Yeah, so, there's a few things that sometimes we have to worry about that can cause, glomerular disease and this type of situation. And usually it's some type of inflammatory process that's occurring. And so that would be one of my concerns is some type of disease that's affecting the patient, resulting in this type of thing happening. So like a type 3 hypersensitivity or something like that.
Okay. So we kind of probably lump them together. This is what you've already said, a protein losing nephropathy, or you even said a glomerular nephropathy. Mm-hmm. So something really localized to the glomerular disease, and the one you suggested specifically was glomerulonephritis, which immune complex disease, or a type 3 hypersensitivity, which is why I'm teaching it now. And another one, a little less common, but also occurs, is renal amyloid, which is also an immune-mediated disease that the students will talk about in GenPath. And you said these are, I mean, how would you got to talk to the owner about this now. How would you kind of explain this as far as, what's causing this?
Yeah. We do run into this in Western Washington because in particular, we have a lot of tick-borne diseases and things like that. And a lot of owners who have, for whatever reason, elected not to maybe have patients on preventative medications. And so we can start to develop these antigen antibody complexes that can start to go to specific tissues. And in particular, one of the areas that they tend to go is to the kidney. And then we start to develop this type of issue where, again, in the glomerulus, inflammation develops and we get this leaking.
Yeah, perfect. Yeah. And one of the things you've said is that there's a cheat sheet for me is that these diseases are mostly secondary, right? The chronic inflammatory diseases. You can differentiate them by renal biopsy, but not many people do that because it doesn't change the way you treat them, and it's not many people are going to go for it anyway. If it persists, the prognosis is not good because it tends to progress to renal failure.
Yeah.
But if you could identify and treat the underlying disease, and that's the primary thing, which is often hard to do, where you have to treat it symptomatically. So the underlying disease you said you see mostly, which is really common, are those tick-borne diseases, right?
Yeah, absolutely. I mean, we're having to worry more about heart disease in this area. It's not exactly endemic to Western Washington, but with so many places that are providing animal rehoming from across the country, we're getting a lot of animals from Texas and other locations that do have heartworm in particular.
Heartworm, oh yeah.
And so we're having to also keep an eye out for that.
So that's be it, like tick-borne disease, that's going to be one where antigen is going to be shed into the blood. And so circulates, and if it binds antibody, then those antibody complexes are going to circulate and then come out in certain places. If you treat this, one of the things I have here is you treat it symptomatically. If you treated it long-term symptomatically, what would that look like, Erik?
So if we're treating symptomatically, really what we're kind of doing is I'd be doing recheck lab works in particular.
Okay.
Kind of looking at that chemistry that we had done before, looking at how are the other kidney values at this time, the BUN, that creatinine, and
Right.
probably doing even follow-up urinalysis.
Okay.
It kind of becomes a challenge because you also have to work with where the client's capabilities and finances are.
Right.
But I'd pick one or the other, and maybe at least initially every 3 to 4 weeks, check on that. And
Okay.
if the patient still continues to do well, starts eating again, all this, maybe I'd extend that out further.
Okay. Would you change the diet?
Yeah, I would. I would increase to a higher protein diet, good quality dog food. Yep.
You're trying to worry about losing protein, so you want to try to make it up and coming in the other end, huh?
Yeah.
So we kind of go like this with our problem list. You've already upgraded this one. You got glomerular disease, and we're kind of presumptively, we don't have a biopsy to prove it, but it's a pretty good working diagnosis. You're going to be probably going to be pretty comfortable working from there, huh?
Yeah, yeah.
And you got to look, you know, do some things to look for underlying diseases, like probably do a tick-borne panel or something.
Yeah, and it's the 4DX is actually the ideal one because it gets most of the tick-borne diseases, and it also includes heartworm test on there too.
Oh yeah, okay. Yeah, the students we talked about that in the immunodiagnostic test. I hope they know what that is.
Okay.
All right,
Yes.
so just real quick, you know, thanks for doing this. This is an example. I'm teaching hypersensitivities in immunology this year. You were lucky I didn't teach you guys immunology.
I had Dr. Mealy.
Oh yeah, that's right. Well, he'll teach in some, but now he's our dean, so our acting dean. So he's
Yeah.
got his hands full. So they brought in the B team.
Yeah.
You're
still an A team to me.
Yeah, right. You know, this is a protein-losing nephropathy. In this case, it was due to the glomerulonephritis immune complex disease. It's part of this section we're talking about it. And you described it really well, this antigen-antibody complexes. Often we don't know what the source is, but we know there are some. And you've named some of the best ones, the tick-borne diseases, heartworm disease. Those heartworms live in the pulmonary arteries, so they shed antigen into the blood. That makes perfect sense. And so that's kind of where it is. And if I had the students in class, I would ask if they had any questions now. But you got anything to add before I kind of do a really quick review on type 3 hypersensitivities?
No, I don't, other than I like the picture.
Yeah, that's Rocket and Tiva. These guys are seeing way too many pictures of Rocket and Tiva.
Well, hopefully they're sending you pictures. I remember you had us send pictures.
That was CISPATH. I don't do that now, so not in immunology, especially this year because we're all doing it live. I don't hardly know who these guys are. It's kind of killing me.
Oh, okay. Oh, that is rough. That is rough.
So just real quick, just to bring back some memories for you. Remember this is the antigen antibody complexes over here that you talked about. These things get deposited in certain tissues, some places in specific, and they're soluble, they're small. And the problem is when they deposit in places, like you said, the glomerulus is one of the primary places. They activate complement, which then that means the complement's deposited in the tissue, and that releases chemotactic factors, which bring in neutrophils. And so those guys have oxidants and enzymes, and they cause more tissue damage. And so altogether, you get inflammation and destruction, and that's what makes the glomerulus leaky. So it starts to exude proteins. Initially, it doesn't affect tubular function, but over time, as it gets more severe, you'll have decreased perfusion of the tubule, and you see animals that progress to chronic renal failure. And that's probably your big concern for keeper, huh?
Exactly.
It'd be nice to hopefully manage that. And remember anything about complement?
A little bit, yeah.
Hopefully, probably not much, because I wouldn't expect you to.
I don't have to use it on a daily basis and talk
no
to
kidding,
my clients
yeah.
usually. Yeah.
So this is the pathogenesis of this lesion here, and let me talk these guys. I'll review this with them a little bit about complement, which they've been studying this semester. So I'm sure, Eric, you remember all this stuff.
Oh yeah, I remember that picture is just burned in my brain right now.
Oh yeah, right. And so we talked to the students about having there's three ways in which complement gets activated, and it gets activated mostly on surfaces. In this case, this has happened in the glomerulus. And that's how they form the membrane tac complex. But among the things they do, in this case, it's activated because of antibody-antigen complexes, so the classical pathway. It releases these soluble mediators I just described. And they have these pro-inflammatory effects, so they cause increased vascular permeability, and the chemotaxis, they bring in neutrophils. And so they have pretty profound effects. And there's a big part of the lesion here. So this is a blood vessel here, and these complement mediators here, C3A, C5A, they have an effect on the blood vessel there. And then they cause increased permeability, so that causes leakage. And they also bring in neutrophils, and that also causes leakage and some damage. And that's kind of the whole thing that's happening here. So you get increased permeability, increased blood flow, all the signs of inflammation. And the problem in this case is that at the site, it means that the glomerulus is leaky, so this stuff all exudes outside into the tubule and gets lost into the urine. And in this case, it's losing a lot of protein, so you're seeing hypobuminemia and weight loss and all those things. Bad memories for you, I'll bet, huh?
It's all flooding back.
Oh, yeah.
I'm sitting in that room going over these slides.
Right.
Or something similar anyway.
And this is a way too detailed version of the same basic thing, but these soluble mediators here are the ones that cause inflammation at the site. And so when these immune complexes get lodged there, that's where we see. And I'll talk to the first years a little more about some of the other places that they get lodged and some of the things that we talk about. But this is the big thing here. They get released and cause that inflammation. And so, you know, keepers, they're gonna probably have to be treated symptomatically for a while. It'd be great if you could identify underlying cause and treat that. I suppose you might try some antibiotics for a while, huh? Just to see if it's got a tick-borne disease.
Yeah, I'd probably even look at like doxycycline or something like that.
Yeah.
To initially see if we can bring that down. Yeah.
All right, man, that took longer than I had hoped, but hopefully it's going to be a useful thing. At least I'm hopefully breaking up the cycle a bit for these guys.
Yeah, absolutely. Well, I would have enjoyed this, so.
You're my friend. You're supposed to say stuff like that.
Oh, wow. Oh, okay, sure.
So I want to say thanks again. You and I will catch up sometime soon, okay? And kind of follow up.
Sounds like a plan. Well, have a great year for all of those in class listening to this.
Okay, Eric, we'll see you soon, and enjoy this nice weather.
All right. Thank you so much. Take care.
So thanks, everybody. Well, we're going to go on now and talk a little more about this, but I hope that was a break and it wasn't too lame for you guys. We'll talk to you soon, and we'll move on to the next section.